respected chairpersons, and my dear friends. Acute respiratory failure in pregnancy is rare. However, it is one of the feared complications of pregnancy. The causes of respiratory failure, when you see, basically, and very surprisingly, is not because of causes related to a lung problem, and more so because of a non-respiratory problem. The causes could be asthma, ARDS, pneumonia, pneumothorax, etc. But the non-pulmonary causes, which are more frequently causes of respiratory failure, are thromboembolic disease, amniotic fluid embolism, venous air embolism, aspiration of gastric contents, and beta-adrenergic tocolytic therapy. Well, numerous mechanical, anatomical, physiological, and hemodynamic changes occur during pregnancy. Some few like hyperemia, mucosal edema, hypersecretion, increased mucosal friability. All these are going to be quite toxic and can be vulnerable to any mother. In fact, the diaphragm is displaced, cephaloid, by 4 centimeters. There is increase in anteroposterior and transverse diameter of the thorax. So all these basically are benefiting the fetus, but leaves the mother vulnerable to any respiratory problem. In fact, even the functions say so. There is 10 to 20% decrease in FRC. Their residual volume is decreased. Expiratory reserve volume is decreased. The total lung capacity is decreased. All these are making the mother more vulnerable to a respiratory problem. There is a 20 to 40% increase in minute ventilation, 50 to 70% increase in alveolar ventilation, increased 30 to 35% increase in tidal volume, and respiratory rate increases. The oxygen consumption increases as much as 40%, and the delivery for an increase of 40% is almost the same. And however, the resistance of the pulmonary circulation comes down. ABG shows a respiratory alkalosis with compensatory renal excretion, which means the oxygen is not going to be delivered easily. Mild hypoxemia can occur in supine position for obvious reasons because of fetal demands and increase in maternal metabolic processes. Well, friends, pregnancy is a respiratory complication-prone state because of hypoxemia and chances of aspiration. Hypoxemia can be because of decrease in FRC, increased alveolar ventilation, and increase in oxygen consumption. And most of the symptoms, respiratory symptoms, are very confusing. You could say it is cardiac symptoms, you could say it is respiratory symptom, and many of the time, the symptoms are basically for any normal pregnancy. The common symptoms of respiratory failure is like dyspnea, cough, hemoptysis, tachypnea, chest pain, and syncope. Physical examination can show cyanosis, clubbing, a gallop, murmur, a labored breathing, rolls, decrease in air movement. So you may confuse it could be a cardiac problem. Chest X-ray shows apparent cardiomegaly, and enlarged left atrium, increased vascular marking, straightening of the left heart border, and postpartum you could have even pleural effusion. The radiological effects, I think Dr. Malhotra has already said, if it is done in the first 3 months of the pregnancy, it can have oncogenicity, teratogenicity, and neurological development can be affected in the fetus if the RADs are more than 5. However, if a radiological investigation has to be done, it has to be done. You protect the abdomen, and if you cannot avoid a unnecessary study, but don't do unnecessary studies. Don't keep doing it every day. For just that the patient has respiratory failure doesn't mean you have to do X-ray, chest, AP, lateral every single day. So then remember that you have to protect the abdomen every time you do an X-ray. Coming to the first of the complication which can lead to respiratory failure, bronchial asthma. Most of the time it's a last trimester exacerbation which can be fateful and which may need admission. It is usually triggered by a viral infection or non-adherence to a steroid medication or in patients who have gastroesophageal reflux. Prostaglandin F2 alpha used for labor induction can induce a bronchospasm, remember. If you have a patient with bronchial asthma laboring, and if you have given prostaglandin F2 alpha, you can end up with a status asthmaticus in these patients. So usually a prostaglandin E is given. With increasing severity of bronchial asthma, you do find fetus with low birth weight, and you may have poor fetal outcome. In the mother, there is high chance of gestational hypertension and premature delivery. If the asthma is mild to moderate, then you have a musical chest. You can have a wheezing, your patient may have dyspnea and labored respiration. But remember, friends, if you find that the chest is silent, then it is time for you to take the patient directly into the intensive care. And a patient with asthma with an FEV1 and PEFR of less than 50% is considered to be a severe asthma. And to such a patient, you may find accessory muscles of respiration being used, and there is mild to moderate breathlessness, there is wheezing, and symptoms are obvious at rest. And such a patient, you need to give an aggressive treatment, give her humidified oxygen, and you see to it that the SATs are maintained above 95%. A PaO2 of above 60 and a SAT of 95% is mandatory to maintain the fetus. So you need to see to it that the SATs are above 95%. Give her inhaled and IV steroids, beta-2 agonists, ipratropium inhalers, all this inhale by using the MDI inhaler. Or you can also give IV ipratropium. And recently in the Western countries, we've come out with tiotropium. And this has to be given every few hours, every 4 hours, every 5 hours you have to give. Whereas in tiotropium, it's a 1 day dose. So it acts for 24 hours. So a tablet of tiotropium can work for 24 hours. Theophylline, if it is very severe asthma, may not be very effective. If you find a patient coming to the casualty with the following problem, with having accessory muscles, and patient is in near respiratory arrest, such a patient, you have to admit the patient. Before admitting the patient in the triage itself, you have to intubate and mechanically ventilate the patient with 100% oxygen. Give nebulized beta-2 agonist and anticholinergics every 20 minutes in the casualty, and give intravenous steroid, hydrate the patient, take a line, hydrate the patient, and immediately take her to the intensive care. If the patient does not improve in the next 1 hour, then in the intensive care, you give 100% humidified oxygen, and then titrate oxygen using pulse oximeter. You take in 2 intravenous lines, consider an arterial line. You have to give IV steroids. You have to give inhaled steroids too. And you have to give inhaled albuterol. If with all this there is no improvement, or in those patients who are not cooperative, you may give epinephrine 0.3 ml and subcutaneously. Anticholinergics, as I said, have to be given. Theophylline, as I said, may not be useful. Other strategies, if all these don't help, magnesium sulfate is very useful. And you have to simultaneously do other electrolyte correction. Heliox in really a patient who is resistant to everything, and consider cesarean section, intubation, and ventilation of this patient. You may try anesthetic agents like ketamine and sevoflurane, which are prone to be useful, especially if the treatment is non-responders, basically. Pneumonia is one of the most frequent cause of non-obstetric infection in the 3rd trimester, and you may, or one of the non-obstetric problem related to obstetric deaths. Patient may develop a preterm labor, and it could have an adverse fetal outcome. Initially, these are the species. Streptococcus pneumonia and Haemophilus influenza are basically the species. Well, you may find initially the mother coming with just fever, with chills, and just dyspnea, not with dyspnea, fever with chills, and then, having ocular symptoms, having some skin symptoms and all that. And you may think it is just plain and simple, probably flu. But once you find that the mother is having labored breathing, then you know that you're having some problem in front of you. Your patient may have developed pneumonia. And it could be unilobar or multilobar. And mind you, a simple pneumonia which you thought will go away in just 2-3 days with some small antibiotics may lead to complications like respiratory failure, abscess, bacteremia, empyema, pleural effusion, or even lung collapse. While treating pneumonia, you have to know that you have to treat even secondary bacterial. It could be complicated by secondary bacterial pneumonia. Viral pneumonia is treated with acyclovir. Pneumonia complicating HIV infection in pregnancy is also being treated with new protease inhibitors, and some of them are being treated with trimethoprim sulfamethoxazole with folate supplementation. What are the safe antibiotics in pregnancy? Penicillin, cephalosporin, and erythromycin are very, very safe because they cross the placenta less effectively. In penicillin allergic patients, and respiratory fluoroquinolone and aztreonam are recommended only if you feel that the patient is simply not responding and if the patient is allergic to penicillin. Otherwise, we basically try to avoid a fluoroquinolone. Clindamycin is found to be pretty safe. And you have to give a cover for gram-negative organisms. So you can give beta-lactam agents along with, if you feel that the pneumonia is severe, you can give fluoroquinolone or aminoglycoside and azithromycin or aminoglycoside and fluoroquinolone. So these are the combinations you can take. And if the patient has MRSA, you can add vancomycin. Tuberculosis, as you all know, can be a major issue in our country, and one of the major problems we feel is the drug interaction and the teratogenic effects of these antituberculous agents. INH, rifampicin, ethambutol are safe, though it crosses the placental barrier. Injection streptomycin and other injectables can cause potential toxicity and teratogenicity, so it is avoided. Interstitial lung disease and cystic fibrosis, which are dangerous because of the pulmonary hypertension which it can cause. So you have to treat the pulmonary hypertension. The pregnant specific conditions, which are basically common reasons for admission for respiratory failure into the intensive care units. The first one of it is acid aspiration syndrome. It can cause severe hypoxemic respiratory failure, and the treatment has to be vigorous airway suctioning, oxygen, IV steroids, nebulized bronchodilators, antibiotics, fluid therapy, and if need be, you can give non-invasive ventilation or even invasive ventilation with PEEP. Amniotic fluid embolism is one of the most catastrophic of them all. It has a dramatic presentation, and it can occur with delivery, uterine manipulation, uterine trauma, and most commonly seen in the early postpartum period. The amniotic fluid contains particulate cellular elements which can enter the vascular circulation. It can obstruct the pulmonary vessels and then starts and give rise to pulmonary hypertension, and it can also buck up the cytokines and cause a total body capillary leak, and it can cause respiratory failure. So this inflammatory response can lead to DIC and altered mentation in the patient. Acute left ventricular failure might occur, and basically fetal distress is also seen in these patients because of all these complications. As I just said, the clinical features, it is a dramatic presentation with dyspnea, hypoxemia, and cardiovascular collapse, hemorrhage, DIC, and all that. And the differential diagnosis to amniotic fluid embolism is septic shock, thromboembolism, etc. Treatment, you have to resuscitate the patient, treat the hypoxia with oxygen, treat hypotension with fluids and isotonic saline vasopressors. Left ventricular diminished contractility has to be treated with fluids and inotropic therapy. DIC and coagulopathy with FFPs and cryoprecipitate fibrinogen, etc. Hemorrhage with RBCs, corticosteroids, and treatment of complication of if the patient develops as ARDS. Other newer strategies are also available. These are the various strategies available for AFE. The sequelae, as I just said, could not just respiratory failure. Patient can present with cardiac failure, a neurological symptom, a renal failure, or even a hematological compromise can occur. Venous thromboembolism is also a common cause for respiratory failure because, as you all know, in pregnancy there is venous distensibility and capacitance, and this venous stasis can be a cause for venous thromboembolism. And also, you all know that pregnancy is a hypercoagulable state, and this could be an additional problem which can lead to venous thromboembolism. The predisposing causes due to venous thromboembolism could be a cesarean delivery, advanced maternal age, prolonged bed rest, hemorrhage, sepsis, and multiparity. Again, obesity in early pregnancy, current infection or inflammatory processes like urinary tract, simple urinary tract infection can give rise to venous thromboembolism. Immobility for too long, if the patient has been flying for too long, recent long distance travel, dehydration, ovarian hyperstimulation and preeclampsia or the other causes. Thrombosis usually start in the thigh or the leg veins, and then it goes up, and as it goes up, patients can develop, once it's give way, you can have venous thromboembolism. And diagnostic test, one of the best diagnostic tests is compressive ultrasonography, a failure to collapse the vascular lumen completely on gentle probe pressure. That is one of the best diagnostic test of venous thromboembolism. It is also very difficult because patient will have a dramatic clinical features as dyspnea, tachypnea, chest pain, apprehension, crackles, and loud P2. And ABG will show hypoxemia because of shunts, hypocapnia, and respiratory alkalosis. Protein S, protein C, and antithrombin levels are below. D dimers are positive, and VQ scans are confirmative. Again, treatment, you have to give oxygen, give graduated elastic compression stockings. Unfractionated heparin to the tune of 5,000 to 10,000 units have to be given. It is very safe. And once you start with unfractionated heparin, you can switch over to low molecular weight heparin because you don't need frequent lab values. You can use it once or twice a day regime of low molecular weight heparin. Warfarin is avoided during pregnancy as you all know, it causes embryopathy and placental disruption. And IPPV with PEEP is mandatory in a patient who is having respiratory failure. Embolectomy IVC filters have been safely done even during pregnancy, and treatment with warfarin should start after the delivery. If the patient has had a venous thromboembolism, if in labor, you stop the heparin. If labor induction is planned, stop heparin a day before. Regional technique should not be employed for at least 24 hours after the last dose of low molecular weight heparin. So depending upon the patient to patient and to your experience, you can avoid spinal or epidural if possible. Pulmonary edema is one of the largest causes of respiratory failure, and non-cardiogenic causes could be because of increase in hydrostatic pressure, increase in permeability, or a decrease in cardiac output. So it could be because of tocolytic therapy, OSA, or severe preeclampsia. Increased permeability can be seen with ARDS, sepsis, pneumonia, etc. And you treat usually pulmonary edema with oxygen, restriction of fluids, NTG, diuretics, inotropes, and ventilation. Caution is nitroprusside can cause fetal cyanide toxicity. ACE inhibitors can cause fetal renal dysfunction. Alpha blockers and beta blockers also can cause problems of low birth weight and placental problem. Pulmonary edema, tocolytic pulmonary edema, usually on giving a tocolytic like say terbutaline, etc., it causes a severe sympathetic response and myocardial dysfunction. The myocardial dysfunction and increase in tachycardia and hypertension can by seeing that the patient has got severe tachycardia, you start giving fluids hoping that the heart rate will come down, and that can cause overinfusion. There is increase in capillary permeability, and if you have to go for a delivery, you start giving steroids to protect the fetus, maturity of the fetus, and ultimately you may end up with pulmonary edema. And preeclampsia, of course, there are innumerable causes: increased permeability, low albumin, myocardial dysfunction, and of course, an overdose of fluids. All of them can give rise to pulmonary edema, and cardiomyopathy because of myocardial dysfunction, tachycardia. All these reasons can give rise to pulmonary edema, cardiogenic pulmonary edema. Or gestational trophoblastic disease and pulmonary edema, it could be because it can give rise to severe pulmonary hypertension, and that can give rise to pulmonary edema. ARDS, it is characterized by alveolar hypoxia, capillary permeability, etc. The recent definition is it is of acute onset, clinical exclusion of cardiac pulmonary edema and respiratory distress, diffuse bilateral patchy infiltrates, and PF ratio of less than 200. The most common pregnancy-related causes are sepsis, aspiration, venous fluid or amniotic fluid embolism, pneumonia, and eclampsia, abruptio, placenta, and a dead fetus. These are the basic various pregnancy-related causes, and issues aggravated in pregnancy because of decreased FRC of pregnancy and chronic compensatory respiratory alkalosis of pregnancy, which reduces the buffering capacity, dilution anemia, and decreased plasma oncotic pressure, that in turn can give rise to non-cardiogenic pulmonary edema, and supine hypotension because of IVC compression can exacerbate an ARDS. So the three aspects of management is initial stabilization, confirm the diagnosis and identify the etiology, assess the fetal well-being, and you have to have a multidisciplinary approach. Ventilation in ARDS has to have a lung protective ventilation strategy of low tidal volume, high respiratory rate, plateau, and keep the plateau pressures below 35 to avoid volutrauma, barotrauma, and atelectrauma. So delivery in ARDS. Vaginal delivery may not be tolerated in a woman with ARDS due to increased oxygen consumption. Cesarean delivery results in fluid shifts and blood loss, and that are both larger and more rapid that occurs with vaginal delivery and may present a greater physiological stress. Decision is based on standard obstetric indications for cesarean delivery, and attempts should be made to optimize maternal oxygenation and pain control during vaginal deliveries. Respiratory indications are the same as a non-pregnant. Severe respiratory or combined respiratory metabolic acidosis, sustained respiratory rate of 40 per minute, abnormal breathing pattern, depressed mental status, and severe hypoxemia. These are normal indications even for non-pregnant, and the treatment should be supportive in the presence of respiratory failure of whatever the reason, treatment of specific disease leading to respiratory failure, sustain normal fetal development without compromising maternal care. Mechanical ventilation with NIPPV, many people say that it can give rise to aspiration, but there are many studies which says that you can use NIPPV with safely. Hemodynamic support, especially if the patient's mentation is okay. And hemodynamic support, nutrition, prophylaxis against thromboembolism. Early identification and treatment of the underlying cause of respiratory failure, multidisciplinary approach, and documentation is very vital in a patient presenting with respiratory failure of pregnancy. Thank you very much.